Welcome to Living Well with MS, the podcast from Overcoming MS for people with multiple sclerosis interested in making healthy lifestyle choices. I'm your host, Jeff Alex. Thank you for joining us for this new episode. I hope it makes you feel more informed and inspired about living a full life with MS. Don't forget to check out our show notes for more information and useful links. You can find these on our website at overcomingms.org/podcast. If you enjoy the show, please spread the word about us on your social media channels. That's the kind of viral effect we can all smile about. Finally, don't forget to subscribe to the show on your favourite podcast platform so you never miss an episode. Now, without further ado, on with the show. Joining me on this episode of the Living Well with MS podcast is Dr Michael Kornberg. Dr Kornberg completed his undergraduate studies at Yale University. He then received MD and PhD degrees from the Johns Hopkins School of Medicine and stayed at Johns Hopkins for Neurology Residency and a clinical and research fellowship in neuroimmunology. He is committed to a career that combines the competent and compassionate care of patients with multiple sclerosis and other immunologic disorders of the nervous system with basic and translational research aimed at developing improved therapies. He is also Programme Director of E-Multiple Sclerosis Review, which is a continuing medical education programme accredited by Johns Hopkins. It includes a podcast featuring discussions about clinical topics and patient scenarios with doctors and nurses treating people with MS in order to educate healthcare providers on best care for people living with MS. If you haven't already, please consider registering at www.overcomingms.org. This way you can stay up to date on all the latest OMS news, including new programs and digital initiatives. Again, that's www.overcomingms.org. And look for the register button in the upper right hand corner of your screen. Now let's get on with the podcast. So welcome Dr Kornberg, and might I call you Michael?
Absolutely. Yeah, thank you for having me.
So to start off with, we've established you work at Johns Hopkins and that covers a wide range of neurological research. But what's your particular areas of research interest?
Sure. So I specialize in multiple sclerosis, both in the clinical work that I do, taking care of patients, and also in my research. I care almost exclusively for people with MS, and I have a research program that in essence is attempting to understand particularly progressive disease and the reasons that myelin repair fails and how we can modulate those processes to better treat people with progressive MS. And I'm also interested in how dietary therapies and basic metabolism impacts the immune system and how we can modulate the immune system in people with MS and other autoimmune diseases through metabolism and diet.
Okay, those are both areas I think which would be particularly interesting to our listeners. So just on the first one, there's an awful lot of drugs and treatments available to try to slow down or prevent MS relapses, lesions and so on. But remyelination, that's almost the holy grail, I think. A lot of people with MS would certainly see that as, okay, we're on a treatment, we're living a lifestyle, we've lessened the progression, but can we get back anything? And is that something, do you see that as something that we will see in the relatively near future?
I do. So, I think that, relatively near future is obviously subjective to some point. And so, I don't think that we're going to have a remyelinating therapy, within the next 2 or 3 years. But, I think on the time scale of 5 to 10 years, I think it's absolutely a possibility. It's easy to, I think for everyone to lose sight of how much progress there's been in the MS world in terms of therapeutics. Up until, almost 2010, there were really only a handful of therapeutic options for relapsing MS. And within the past 10 years, we've had this explosion of therapies. And as a result, I think we are in a pretty good place in terms of the treatments that you discussed, in terms of preventing, new attacks of MS, new flare-ups, new lesions from forming on MRI, which we know makes a big difference in the course of someone's disease. And so, the goal is always going to be to diagnose MS as early as possible and start those treatments as early as possible. But we're always going to have a group of people who unfortunately have been left with permanent disability from prior attacks, and we are at a place where I think that over the past 5 to 10 years we've gained a lot of knowledge about why myelin repair fails in people with MS, and what drives that process. And there's a big gap between understanding why that happens, in a research lab and kind of translating it into something that we can give to patients. But I think already we've made a lot of progress in terms of understanding how to measure myelin repair in people. And we have a lot of good candidates that we can take from kind of the research lab, into clinical trials. And so, I don't think we're a couple years away, but I certainly think, within the next 10 years, it's reasonable to think that we will have therapies for myelin repair.
And so is it even possible that someone with progressive MS who might be wheelchair bound now, that actually there could be some level of reverse of their symptoms? Or would it be a stabilization?
So a little of both, but I think it's important to kind of set reasonable expectations, at least, and the caveat to everything I'm saying is that this is my opinion, it's my interpretation of, the data we have now and what I expect the progress is going to be in the future. That there's kind of two separate goals, that you mentioned, kind of halting progression and actually promoting recovery of function. And I think to an extent, there might be different therapies that are targeted at those two kind of distinct elements. So I do think it is going to be possible to repair myelin and actually lead to recovery of function. But I think it's important to be realistic about what we might be able to expect in that scenario. So those remyelinating therapies are going to be most effective in people earlier on in the disease, who have not had long-standing severe disability. For the reason being that in later stages of MS, people who have had progressive MS for a long period of time, one big problem is that, the brain atrophies. You actually lose those nerve cells themselves. And so, whereas it's easier to repair the myelin coating, that covers the neuron processes, it's much, much harder to get neurons to regrow. And so at the later stages of MS, where you just don't have the neurons there to remyelinate, that is a big challenge. And so the goal with remyelinating therapies is still going to be to treat people early on in the course of their disease, before they've gotten to a point where there's been neurodegeneration and we've just lost brain tissue that we can't get back. And I think along those lines, I think what I would have in mind, what I would hope for, as a realistic goal in 10 years is that, if someone has, lost vision from an episode of optic neuritis, which is common with MS, that, we can get their vision to improve. If someone has difficulty walking, that we can create a meaningful improvement in their walking ability. If you're talking about someone who is wheelchair bound and has been wheelchair bound for years, kind of getting them out of the chair and walking, that is a very ambitious goal. And I wish I could say that I think that is realistic to consider in that time frame, but it's probably not. And so, I have in mind, making improvements in people's function that is meaningful to them in their life, but we have to have some realistic expectations of what that'll mean.
Okay. The other thing you mentioned as a research interest is diet. Now, overcoming MS is a lifestyle charity, so which includes medication as well. So it also, we look at diet, exercise, mindfulness. So do you think that diet has a meaningful effect on the progression and immediate lifestyle of someone with MS?
So I think it does, but I also think that we don't know nearly enough about what specific diets are best for someone with MS. And I think that we have a tendency to get carried away in some of what we extrapolate from, what we see in research models versus people. And so, ultimately, there are certain things we know for certain. We know that people who are overweight or obese tend to have more significant disability than people who aren't over time. We know that people with certain comorbidities like high blood pressure, high cholesterol, that they develop more disability over time. And I'm talking about people with MS who have these coexisting conditions. And so, generally we know that healthy diet, a moderate amount of aerobic exercise, that these things aren't just generally good for health, that they're particularly good for people who have multiple sclerosis. The next question that comes up is, what diets are particularly good for MS, or what diets, kind of protect, my brain from being attacked by the immune system, or, promote recovery of function. And that's the place where, there's a big chasm between, what we're finding in the research world and what we've seen in people. And so, I'm someone who is a strong believer that basic, cell metabolism, and because of that, diet can have an impact on how the immune system functions and possibly even how the brain repairs itself. But we really don't know, in people, people are always much more complicated than what we're studying in the lab. We don't yet know, which of those diets, are helpful, which aren't. And so, we see a lot of things on the internet about, this food being pro-inflammatory, this food being anti-inflammatory. And in my opinion, that goes well beyond what we really know at this point. And so the way that I counsel, my patients is that, as a general rule, kind of the same prescription for general living we would give to everybody, everything in moderation, favor whole foods over processed foods, getting, moderate aerobic exercise. If someone really wants to have a particular diet to follow, because, for some people that structure is helpful, I always recommend the Mediterranean diet, which is really the only diet that has clearly been shown to have a broad health benefit in people. Some people, there's a number of other diets that your listeners might be familiar with: the Wahls diet, the Swank diet, paleo diet. And the way that I talk to patients about it is that generally, if someone kind of commits to one of those diets, usually their diet is improving relative to what it was. And, they're often going to lose weight. They're often going to feel better. And so, as long as it's not some extreme diet that really carries some potential risk, I am all for it. And so, I kind of just recommend to people that they do what works for them. I'm in my research, I'm particularly interested in ketogenic diets because of how that might impact the immune system that, we've seen in research models. But I'm very wary, when I talk to patients, the fact that, you have to understand that things like a ketogenic diet that are very high in fat, we don't know what the negative consequences might be of that over time, in terms of cholesterol levels, and that's all being studied. And so, it's worth talking about your dietary choices with your doctors, and we need to understand that we don't have great knowledge yet about, how some of these diets, their effects on the body over time, but generally, healthy diet, certainly is an important part of the care for people with MS.
Mm-hmm. The overcoming MS, promote it's based on originally on swank, but it's essentially a whole food plant-based diet plus seafood. And yeah, I mean, as you say, I mean, I asked my neurologist when I first decided to go this way, and he said, well, there's just no proof out there. We just don't have the evidence base. But he said ultimately, it's going to be good for you, and it will reduce your risk of heart disease, strokes, diabetes, all these other things. So he said, you know, if you look at the upsides and the downsides, it's not going to do you too much harm, and you might miss some of the things that you liked to eat, but other than that, it's not going to do your health any harm. But yeah, the problem is getting the research, isn't it? It is a very difficult one. You can't have a double-blind placebo trial of someone eating one thing or not eating that thing. You know if you eat it or not. So it's a bit of a tricky one.
That is very hard. And you know, I mean, diet studies are really hard. You know, which is why you know, it's that science is lagging behind. You know, but we're getting there. I mean, they're not impossible to do. And you know, I'm currently doing a dietary study with ketogenic diet, and so it's possible, but it's much harder, you know, than a randomized drug trial.
And you mentioned ketogenic diets. There's a lot of people that I come across who are quite successful in their MS treatment who use fasting, and that they're saying that's a way. And actually, there's Val Salongo, who's very much into fasting. He was saying that's, you know, primarily what you're doing is you're getting the body into that ketogenic state. So it's not what I think people traditionally think of as ketogenic, which is that specific diet where you're eating very, very high fat. These they call bulletproof coffees or something, where people have like massive amounts of caffeine and with butter in it, and so they're specifically eating very high fat, very low carb diet. Yes, that would get you into ketosis, but also so would fasting. So it's like you don't have to go down this very high saturated fat route. You can actually get some of the benefits in other ways. So fasting isn't a pillar of OMS. It's not something that's particularly mentioned, but I think it's one of those areas that is of particular interest because so many people are mentioning it. And is that something where you think maybe a fasting method and introducing ketosis through fasting may prove to be something that's the future?
Yeah, so absolutely. I think it may be, but you know, I would still put intermittent fasting in the category of we just don't know, you know, whether it is beneficial, you know, for people with MS and what the potential downside might be in the long run. And so I think it is certainly an exciting, you know, area of research, not only for MS, you know, but for, you know, a whole host of human diseases. And there certainly is a lot of, you know, at the, you know, the level of, you know, animal models, there's, you know, a lot of great evidence, including, you know, work that you already mentioned from Dr. Longo's group, looking at intermittent fasting in MS animal models. And, you know, there's a lot of, you know, when, you know, people who do that research will make the argument that, you know, that we evolved as humans in a, you know, kind of an intermittent fasting type of model because, you know, when food wasn't so readily available, you know, you go these long stretches without eating and so the body is kind of designed to work that way. And that's a compelling argument. But, you know, still, I think, you know, we have to be a little bit careful about, you know, taking you know, what sounds like a very plausible hypothesis and has some support, you know, in animal models and just extrapolating it to people without doing those studies. And so, you know, again, you know, what I tell people who want to do intermittent fasting is as long as they're not doing something totally crazy, you know, then, you know, I'm all for it. And, you know, generally they are going to, you know, be healthier, just like we talked about, you know, with all those other diets, because, you know, if you are, you know, if you're kind of condensing your eating to 8 hours during the day, you know, you eat less, you know, absolutely. And there may absolutely be something about, you know, the ketosis that you enter into during those fasting periods that's beneficial. But, you know, we just need to have better evidence in people before I think we should be recommending that broadly because, until we have that data, it all remains an extrapolation, and we don't know for certain that there couldn't be any downsides to doing that as well.
Yeah, I mean, there's certainly in my lifetime rather, and certainly in, like, go back to my grandparents, the way we eat has changed massively. So I've got teenage children, and we're just asking them earlier what they wanted to eat tonight, and they can eat anything. And it's like we're going to go to the supermarket, so they can eat anything.
Yes.
When I was growing up, the vegetables had to be in season. So you couldn't eat, there was there was a big thing about asparagus because asparagus had a really short season. So you had to, if you had it this time of year. Now you can have it at any time of year because it's flown here from Peru or Kenya, so you've got the whole globe providing, somewhere it's in season around the world. And it's just, if you think about it, it's crazy, really. You can actually, literally, I just thought, we are asking them what you want to eat tonight, and they have no restriction. They have global, they can eat anything from around the world because it's all available locally in a supermarket to us. And that, is such a modern phenomenon. And maybe there are like downsides to that. Maybe it's, the 100,000 years of human evolution hasn't really prepared us for this sudden, consumerist state we have.
Yeah. Well, one thing that I do feel, comfortable saying, given the evidence we have now is that I have little doubt that, our traditional Western diet that we've become accustomed to because of all of those things you mentioned is not ideal. That I think is probably fair.
Yeah. And I think the processing as well is another thing, which we don't mention too much on OMS, but there's some other people I've talked to about this, and they say, if there's a large number of ingredients on the back of the packet, it's probably not very good for you. And that doesn't mean that any of those ingredients are necessarily you think, oh, that's really, really bad. But it's just like, how can something which is an evening meal be wrapped up in a packet, go in a microwave, be eaten? You look at the use by date, and that's 3 months in the future, and you think this is not natural food. And it has huge numbers of different ingredients in there, and I'm sure it tastes delicious, but it's not traditionally what you'd assume something was food because, it's not normal. They did it with I won't say the brand, but a popular hamburger, and they left one out for 6 months or something, and it hadn't.
I saw that.
It looked the same. You're like, okay, if molds aren't eating this, then maybe we shouldn't be eating this. Anyway, that's really interesting. But this episode is actually going out in the month. We sort of have themed months, and it's a month looking at pregnancy and children. So I just wanted to ask you a bit about pregnancy and MS. So if someone has MS, I'm thinking of women here specifically, would it affect them planning to have a baby? How would pregnancy affect someone with MS?
Yeah, so that is obviously a very important question, particularly when you're talking about a disease that, affects primarily women who are average age of 30 and kind of right in that time period to have pregnancy. So women with MS can absolutely get pregnant. Sometimes it's useful to have some planning and strategy around it. So some basic things to cover. So number one, we know that that women with MS do not have any greater complications related to pregnancy as women who do not have MS, and so that can be a concern for people. And I can be very reassuring that if you are a woman with MS, your pregnancy is just as likely to go smoothly as any other woman's. We know that pregnancy itself does not have any generally does not have any long-term impact on your MS. So you're not putting yourself at risk of greater disability in the future by having babies. So what we do know about pregnancy and MS is that pregnancy itself is almost like being on a disease-modifying drug. It protects you from relapses, from MS attacks. And we think that's because pregnancy is kind of naturally an immunosuppressed state because, obviously you don't want your immune system attacking, the baby in utero. And so particularly in the third trimester, relapse rate goes down significantly compared to what it was before. We do know that the risk of having an MS attack goes up considerably in the few months after giving birth. And so, that 3 to 6 months after giving birth, you can see kind of a rebound effect in which the risk of having an attack is actually a bit higher than it was right before you got pregnant. There are associations that women who breastfeed for 3 to 6 months tend to have a lower risk of that kind of rebound effect, but we don't know exactly whether that's causal at this point, whether breastfeeding actually does protect you from having an attack. And so those are some kind of key features that I think are worth mentioning. Related to all of that is what you do with the disease-modifying therapies that that a woman either is on before pregnancy and when to restart after pregnancy. And so, generally speaking, it's always possible to work around whatever therapy someone is on, and there's a little bit of very good MS neurologists can have some differences in how they practice with regard to disease-modifying drugs, but at this point we have pretty good evidence that the interferon therapies and glatiramer acetate seem to be safe even to continue through pregnancy. We have large registries, including lots of women who've gotten pregnant on those medications, and there has been no signal in terms of complications of the pregnancy or risks to the baby. Other medications, the general consensus is to stop them, roughly 30 days before you were attempting pregnancy, but there's some kind of wiggle room there and some things that, as a woman considering pregnancy, you just need to talk to your neurologist about, so there are some medications that if you just suddenly stop them, your risk of an MS attack can go up considerably. So, thinking about like fingolimod, which goes under the name Gilenya, and other medications like that, or natalizumab, which goes under the trade name Tysabri. And so, if you're on one of those medications, you have to strategize a bit with your MS neurologist. And then for some of the newer, what we call B-cell therapies, things like ocrelizumab, which is Ocrevus, and now there's another form, Kesimpta. There's just some timing issues. So, generally, if you get a dose of Ocrevus, I recommend to women that you wait 2 months until you start trying to conceive, because in that case, by the time the drug can cross the placenta, it's kind of out of your system, and so there's some strategies involved in terms of when to stop disease-modifying therapy, whether to continue it during pregnancy, and then when to restart it afterwards, that are just worth having a plan for. But the bottom line is that women with MS can and should have children and do it in a very safe way, and so it's very possible, and you don't have to worry about risks to the baby or risks to your disability in a general sense.
Okay, excellent. So just worth speaking to your neurologist in the planning phase. And connected with that, normally connected to pregnancy, children. So I think people with MS are particularly aware of there being some genetic component, although this was long disregarded. It was like, I think, and then still they don't really know what's exactly going on, I believe. But is there a very highly elevated risk for children of people with MS? Because I'm aware because my father had MS, but I know there's a cause and effect thing going on here. It's like just because you're more likely your parents had it doesn't mean that everyone with MS's children will have MS. But I've got children, so I sort of do have a personal concern. You sort of worry is it more likely that they'll get MS? I know there must be some link, but how much more risky is it for children and people with MS?
Yeah, no, it's a great question, a very important question, and we are starting to understand the genetics, the genetic relationship of MS, in a better way. So there certainly is a genetic contribution, and we know that firmly now. We've identified a number of genes, that can confer, increased risk of MS. But there's also a big component to your risk of MS that has nothing to do with genetics. And so, just to give you, some kind of key figures, if you have a first-degree relative with MS, so for instance, with your father, or if you have MS and you're going to have a child, generally, in most studies that have been done, the risk that your child will have MS is somewhere between 1% and 5%. 3% is kind of the typical, the typical reported number. So, you have MS, your child has roughly a 3% risk of having MS. That is much higher than the general population. It's about 10 times higher, than the general population. So clearly there's added risk there. But I think it's important to emphasize that it means that, that there's a 97% chance that your child will not have MS. And so, still the chances are much greater that they would not, than they would. If one of the, I think the most fascinating data we have is with identical twins, one of which develops MS. And we know that if one identical twin has MS, there's about a 25 to 30% chance the other twin will. And those are two people that have identical genes, right? And so, that's a very high risk, 25 to 30%, but clearly it tells you that there's a lot of factors that have nothing to do with your genes also. So there's a genetic risk. It's something worth knowing about, but the bottom line is that chances are, your child will not have MS.
And those identical twins presumably grew up in the same part of the world, had the same diet, had the same lifestyle, and there's a lot of factors going on probably in their first, say, 20 years of their life, which were almost exactly the same, because siblings are likely to, be treated the same, aren't they? So there's that as well. And another sort of unknown is there does seem to be a geographic component as well, doesn't there? Sort of how close you are to the equator, and certain Western countries have higher instances than others. So.
Yeah, no, absolutely. There's been some debate, that the textbook kind of answer has always been that, that the further away you are from the equator, the higher your risk of MS, and that's where this theory came up, that vitamin D levels might have something to do with risk, because the further away from the equator, the less sunlight you're exposed to. There's been some debate about whether we still see that sort of geographic variant consistently, but along those lines, one of I think the more fascinating things about MS epidemiology is that, just like you said, different areas of the country have different rates of MS. And we know that if you move, from your place of birth roughly before puberty, by the age of, 11 or 12, that you take on the risk of the area that you move to. Whereas if you move after puberty, you maintain the risk of the place where you came from. And so it does seem like there's some sort of environmental exposure that happens very early on in life that kind of sets the process rolling.
Yeah, I think vitamin D seems to be a hot topic at the moment as well, because most people I know with MS are supplementing to some extent with vitamin D. And there's another person I spoke to, Aaron Boster, who's a MS specialist in Ohio. And one of the things he said is when you're looking at things that you're considering a lifestyle, what potential good does it do you? What potential harm does it do you? How much does it cost you? Look at these sort of things. And something like vitamin D or vitamin D, what potential good is it going to do you? Well, there's potentially lots of things. It may be good for your MS.
it might actually help you with other conditions as well. There's a likelihood that we are somewhat deficient, almost everyone, because we're walking around fully clothed and in offices, which is not natural for humans, and living a lot further away from the equator than would normally be possible. And what are the downsides? Well, if you take huge amounts, you can get calcium problems and get kidney stones, and the cost is fairly low. So yes, it's probably worth sensibly supplementing, and it shouldn't do too much harm. So I think a lot of people with MS are supplementing, and then recently there's people who've been saying, oh, we're having trouble getting hold of vitamin D because it's now being widely regarded as helping with coronavirus, COVID-19 symptoms. So then the mass population have started to buy it because I think they do. I think they're pretty certain there is some sort of connection with your vitamin D levels, but again, they don't know its cause and effect. They're sort of saying is it because you had low vitamin D that you got coronavirus, or was it the coronavirus which caused your vitamin D levels to go down? And so, but again, does it hurt to take a small amount of vitamin D? Probably not.
Yeah, I mean, I think you said that all very eloquently. From my perspective, that's exactly how I phrase it for the people that I take care of with MS, is that there's this very clear association that people with lower vitamin D levels have a greater risk for MS, and those who have MS tend to do worse. What we don't know for certain how much of a difference it makes to give back vitamin D, and there's some research suggesting that, kind of like you mentioned, having a low vitamin D level is kind of causally related to your risk for MS, but it doesn't necessarily help to take supplements. But on the flip side, as long as you're not overdosing, just like you said, there's no downside to it. It can only help. There's no risks, and so generally, I do have all my patients taking vitamin D supplements if their levels are low, and so I think that's exactly my take on it as well.
Okay, and another area I'd be particularly interested in is where you see things going in the future. So in the relatively sort of short term, 5 to 10 years, is there anything on the horizon where you think that there's new treatments or any changes to advice that you'd be giving to people with MS upcoming?
Yeah, so there are a number of interesting things on the immediate horizon. Some of the if I'm really thinking the short-term horizon, the next couple of years, one area is there's been kind of this debate in MS care between kind of two strategies of therapies. So one camp is called the escalation approach, where you start with an MS treatment, that maybe has a low risk, but is, also overall less effective, and you only kind of escalate someone to something more aggressive if they have breakthrough disease, meaning they have an attack or they have new lesions on their MRI. And the other camp is, time is brain, and, we should be starting everyone on these high efficacy therapies, very early on in order to, kind of stamp out their disease early on. And the whole field has kind of, moved more towards being aggressive early on. And, we were talking about Dr. Giovannoni earlier, and, he certainly is a proponent of being aggressive early on. My own view is that there are still some unknowns there in terms of, long-term safety. And so there are studies ongoing right now to kind of randomize people between those approaches, meaning an escalation approach versus a high efficacy approach, to figure out, if we can identify patients, that we know need aggressive therapy early on and are going to benefit from it, and those, that maybe, we're better off starting with a safer option. And so I think that's, one big debate, that we'll likely have an answer to some extent within the next few years. Along those lines, there's been some interest in blood stem cell transplants as a way to almost kind of cure. I use that in a very cautious way. cure, the underlying problem in MS, meaning to kind of reboot the immune system so that those autoreactive cells aren't there
is it
anymore.
homeopathic stem cell therapy?
So it's hematopoietic.
Sorry.
Which just means blood, blood stem cells. The idea being that people are treated with high doses of essentially chemotherapy agents to basically ablate their immune system, get rid of all of those autoreactive cells, and then they're given back their own hematopoietic stem cells from their bone marrow to kind of repopulate their immune system, and it's kind of like rebooting a computer. The hope is that you've now kind of solved their autoimmunity problem. Doesn't mean that you're going to repair damage that's already been done, but the hope is that you're kind of preventing further damage, and there's studies going on to compare that approach to standard therapy, and so I think that might make a practical difference in care over the next few years. In terms of new therapies, there are a number of things on the horizon, that may or may not have a big impact over the next few years. And so, there are a number of therapies that are being designed largely for relapsing MS, but there's, some at least reason to believe or some hope that they might have a role in progressive disease. There's a new class of drugs called BTK inhibitors that target cells in the brain that we think play a role in progressive disease, and so there's some hope there. There's some treatments being tested that target immune cells that have been infected with Epstein-Barr virus or EBV, and there's this long-standing association between EBV and MS risk, and so there's some interest there in terms of what that might mean even for progressive MS. And there's a number of other treatments that are targeted, either at preventing brain atrophy or myelin repair that I think on, the span of like 5 or 6 years, we'll have, some data about. I don't think those are going to be home runs in that period of time, but I think are going to kind of, possibly give us something to actually protect the brain beyond just, our treatment of the immune system, essentially. That's a little summary of what I see happening in the next few years.
Okay, and finally, so we're quite a long way into the coronavirus COVID-19 pandemic now, and depending on what part of the world you're from, most people are well into a vaccination response now. And something that's particularly of interest to people with MS is, would they take a vaccine? And depending on what disease-modifying therapy they're on, whether that would have an effect, and which vaccines, some vaccines safer than other vaccines, and would you encourage people generally to get vaccinated if they're on a disease-modifying therapy?
So the short answer is yes, absolutely. People should get vaccinated. The longer answer is that when it comes to vaccinations and MS, there's generally two concerns that arise, both for people with MS and for the doctors that care for them. One is the concern about whether a vaccine might actually induce a relapse, induce a flare-up. And that has been a concern for decades, and there is a theoretical basis for it, that you think of MS as a autoimmune disease, if you're giving someone a vaccine, that's designed to create, an inflammatory immune response, could you trigger a relapse? So generally speaking, when we look at a wide variety of vaccines in terms of the risk of causing an MS attack, we don't see any risk there, and so that has been very well studied with the yearly flu vaccine, but it's been studied with a number of other vaccines, and generally speaking, we have not seen any increased risk of MS attack with vaccines. And so, extrapolating from that, we think that the COVID vaccine will be equally safe from that perspective. There now has been one study in Israel, where they've vaccinated the vast majority of their population. One study looking specifically at people with MS who have gotten COVID vaccines there, and there has not been any increased risk of having an attack, from the vaccine. And so, generally speaking, there's not really reason to be concerned about that. The other concern is if you're on a medication that affects your immune system, is the vaccine going to be as effective? And there are some considerations there. So generally, we know that people on medicines like the interferons, the glatiramer acetate, dimethyl fumarate or Tecfidera, that really, those kind of immunomodulatory treatments, they don't have any impact on vaccine response. And so they're not going to decrease the efficacy of the vaccine. There are certain medications that you do have to think about timing and the potential for affecting, your response to the vaccine. Most notably is the B-cell therapies. So that's Ocrevus, now Kesimpta, someone who's on rituximab. Those work, by getting rid of cells that are important for antibody production. And so we know, from other vaccines that they can decrease your response to the vaccine. We think, that by delaying your vaccine, depending on the guidelines, from 4 to 12 weeks after your dose, you might be more likely to have a protective response. If you're about to start on one of those medications, if you can, getting vaccinated before you start on the medication. But the bottom line is that, even for people on those medications, they may not have the same level of protective response as someone else, but most people still develop some level of protective response. And so, it's still worth being vaccinated. And so, we think everyone should get vaccinated. Depending on your medication, there may be some timing issues that are worth discussing with your neurologist.
Okay, that's very reassuring, as I've been vaccinated, so I'm glad to hear that. So with that, thank you very much for joining us, Dr. Michael Kornberg.
It was my pleasure. Thank you for having me.
Thank you for listening to this episode of Living Well with MS. Please check out this episode's show notes at overcomingms.org/podcast. You'll find all sorts of useful links and bonus information there. Do you have questions about this episode or ideas about future ones? Email us at podcast@overcomingms.org. We'd love to hear from you. You can also subscribe to the show on your favourite podcast platform so you never miss an episode. Living Well with MS is kindly supported by a grant from the Happy Charitable Trust. If you'd like to support the Overcoming MS charity and help keep our podcast advertising free, you can donate online at overcomingms.org/donate. Thank you for your support. Living Well with MS is produced by Overcoming MS, the world's leading multiple sclerosis healthy lifestyle charity. We are here to help inform, support and empower everyone affected by MS. To find out more and subscribe to our e-newsletter, please visit our website at overcomingms.org. Thanks again for tuning in and see you next time.